دكتور عبد العزيز. Dr. Abdulaziz Al-Ghamdi is a pediatric radiation oncologist at King Faisal Specialist Hospital in Riyadh, with specialized training in proton therapy for pediatric tumors from the University of Florida. After he completed his MBBS at King Saud University, he pursued radiation oncology residency at Queen's University in Canada. And Dr. Al-Ghamdi further honed his expertise at the University of Florida, focusing on advanced proton therapy techniques. Without further delays, Dr. Abdulaziz will be talking about radiotherapy in medulloblastoma, evolution of treatments and current standard and future direction. Okay, Dr. Abdulaziz.
Assalamu alaikum. Thank you for the kind introduction. So today I'm just going to try and tackle this big topic. Medulloblastoma is as old as radiation oncology itself. It's an interesting topic, and I do have a personal experience with medulloblastoma, which made interestingly was the reason why I pursued radiation oncology in the first place. So today I'll be talking about the radiotherapy in medulloblastoma, evolution of treatment, current standards, and future directions. And essentially, this is the story of how radiation oncologists cured medulloblastoma and continue to do so. So I'll first start by asking the question before all questions: what is medulloblastoma? This is a question that was answered by Harvey Cushing and Dr. Bailey back in 1926. And this is actually the original manuscript where they discovered or reclassified medulloblastoma as a separate entity. Back in the days, the early days of neurosurgery, all of brain tumors, primary brain tumors, used to be called gliomas. However, Harvey Cushing and Bailey did this groundbreaking research where they distinguished medulloblastoma from other gliomas. And they detailed 29 cases, post-mortem cases, where they described this tumor that arises in the midline, in the roof of the fourth ventricle. And at that time, when they first described this tumor, it was a pretty fatal disease with a median survival of 7 months. And most of these kids would present, this is an excerpt from the original paper. It's a patient, they labeled her as case 7. Her name was Mary, and they basically went through everything from the presentation, the surgery, and the post-mortem examination. And they have a pretty detailed account of all these 29 cases. The role of radiotherapy actually came through shortly after they started to classify this tumor as a separate entity. These are the earlier case reports from the 1930s, indicated the role of radiotherapy following surgical intervention. However, despite this intervention, the disease ultimately proved fatal. The treatment also was not fractionated. This is Bailey, who is the neurosurgeon / neuropathologist who first described this with Harvey Cushing. And these are two radiotherapists in the US who first treated this. And this is their technique, which basically was an orthovoltage technique. So the story of curing medulloblastoma actually started across the Atlantic, in Edinburgh, to be specific, by Dr. Edith Patterson. She was a radiation biologist at the University of Edinburgh, and she published this seminal study. At the same time, there was also a group out of the US, out of University of Michigan at Ann Arbor, that also experimented with radiotherapy. And these two pivotal studies, the one in 1949 by Lamb and McIntyre, reported the results of RT to the entire neuroaxis of Christie Hospital reported a 41% by using chemotherapy. And if you go back to these original studies, you would read an elaborate description of their technique, how it was done. And they actually prove that radiotherapy to the entire central nervous system cures medulloblastoma post-surgery. They had different techniques and different fractionation, but the story kind of evolved after the way that Dr. Patterson completed her study. These are the first kind of a few long series of treatments where they used this technique of whole CNS radiation, or what we call it today as craniospinal radiation. The first on the left is the one that was done by the late Derek Jenkins out of Toronto, who did 49 cases, which spanned 25 years. And he was able to show that improved survival rate around 30%. He also managed to report the main site of failure, which was the posterior fossa, and also showed some signal for posterior fossa boost. The second on the right is the report out of the Royal Marsden in the UK, where they also continued with the same method. It was around the same time. They had a notable 38% cure rate, mirroring the finding by Derek Jenkins. And there are other groups like Simon Levet out of Minnesota and other groups who have provided their long series showing that whole spine radiation can cure medulloblastoma after surgery. So this is the thing about medulloblastoma is early on, back in the 70s, physicians, pathologists, neurosurgeons, radiation oncologists recognized that there is heterogeneity into this type of tumor. And but that was never explored in terms of prognostication. In the 70s, a group out of the US showed a report of 201 cases where they managed to show that the two histologic subtypes that were recognized. So it's the first histologic subtype that was called classical is named classical after the original description by Harvey Cushing and Bailey, where they described a cellular tumor consisting of small round cells that looked hyperchromatic nuclei with coarse chromatin. The other type, which was described as desmoplastic, was described by another group out of Chicago. They essentially described islands of cells entirely devoid of connective tissue, surrounded by fibrous stroma. And if you could look at this, they actually, I don't know if it's clear here, but they described it as glomeruloid. It looks like a glomerulus. And they recognized in this report that these are prognostic for patients, where you could see here that the desmoplastic group, 24% of them lived out to 10 years, whereas the classical type, they had Basically, medulloblastoma was recognized early on into the pushing the tail end of the survival curve, the use of chemotherapy. So it was recognized that the radiotherapy did work. We kind of managed to get overall survival up to 40%, 50% with some reports. But more and more people were interested in pushing the tail up for the survival. And actually, the first study that was back in the 70s was SIOP-1 that looked at adjuvant chemotherapy for medulloblastoma. And essentially, in this study, the role of chemotherapy initially for medulloblastoma was for recurrent medulloblastomas. But the group went on and used chemotherapy as a radiochemotherapy with following chemotherapy after the concurrent chemotherapy. And they managed to push the overall survival at 10 years to 53%. They also recognized that the relapses occurred in the chemotherapy arm, which kind of dulled down the effect down the road for the chemotherapy out at 10 years. But that was something where a lot of people got interested in, and a lot of trials ensued afterwards. This is also another study that was done by the children cancer group in North America. They did a similar design, and they did show that there is similar effect, and the effect was actually more pronounced for chemotherapy with patients who had more advanced disease. They showed the age as a prognostic factor, also the M stage as well. And if you look at this group here on the right, these patients who have very bad features, M1 to M3, T3 to 4, and you see if we just gave RT alone, the survival was almost nil. However, we recognized early on that there is a cost to this cure. And there was a lot of work that was done by Louis Constein out of Rochester, as well as the group at St. Jude, recognizing the effect of radiation on growth hormone and the neuroendocrinological sequelae of radiotherapy. Also, Roger Packer, who is actually is the lead on a few of the studies in medulloblastoma with dose escalation, did this really exhaustive review of cognitive deficits in long-term survivors of childhood brain tumors. And essentially, the range for cognitive impairment was 20 to 40% for all these patients who received radiation treatment. So there is also the childhood cancer survivor study, which also indicated increased risk of having a second cancer after these type of treatments. So this leads us to the current era of delivering radiation treatments, where we're trying to mitigate the radiation sequelae and improve on our treatments. So most of the stuff that I presented so far were historical things, but kind of was a segue into where we're headed next. So the current standards essentially was to maintain excellent cure rates and reduce the burden of side effects. So there were a few permutations where a radiation oncologist and medical oncologist as well tried to come up with more innovative ideas with reducing treatments. They already recognize that there are bad actors, patients with certain features that need escalation of treatment, but there is also good actors, patients with average risk and certain prognostic features that where you could start by dose de-escalation. So the first study, the first trial was the dose de-escalation. It was CCG 923, as well as the A9661. So in this study, it was a dose de-escalation study, but this time it was just radiotherapy, no chemotherapy, and it was a big problem. We had a lot of failure in these patients, and actually the study was study by Dr. Packer, who as well was involved with the initial work to look into reducing the radiation dose. Is a culmination of previous studies. It was in 2004. He had 421 patients with non-disseminated medulloblastoma who were treated with 23.4 grays of CSI with a 55.8 gray of pseudophasa boost. And it was a comparison between two chemotherapy regimen. One had cyclophosphamide and the other one had CCNU. Essentially, they were equivalent with excellent event-free survival. We're talking about 80% now with in these specific groups of average risk patients. The second way that radiation oncologists and medical oncologists will try to de-escalate was with a volume de-escalation study. So the first one was the M4 study that came out of France. The lead was Eric Buffet, who was the ex-SIOP director. So this study, they tried to spare the supratentorium, and the reason was they wanted to spare the temporal lobes and hopefully improve the cognitive outcomes of these patients. However, they had high rates of recurrences developing in the supratentorium. And this study was, although this study was in the modern era, they had chemotherapy on board at that time, but it was a big problem with the failure in the supratentorium. This leads us to the ACNS 0331, which is the most recent study. I believe it was by Jeff Michalski and was published in 2016. This study had essentially two randomizations. One was for a dose reduction to 18 grays, and the other one was a volume reduction for the instead of boosting the whole posterior fossa, just boosting the surgical bed. And this study was negative in terms for dose de-escalation because they had failures. And the reason was that they had the group 4 patients they've done poorly with dose de-escalation of the CSI. However, for the involved the posterior fossa versus the involved field RT, they were pretty similar. And this kind of takes us into this new standard of care where we boost only the tumor bed with a margin. So these are old historical data on volume de-escalation. It's one of the things that worries a lot of radiation oncologists is trying to cut the volume small, or trying to just treat the involved area and just skip treating the spine or whatnot. And these are the data back from, I believe it was in the 50s and 60s, but it's still relevant today and was proven by modern series, the study by SIOP, that if you try and miss any of the, or intentionally volume reduce, you might run the risk of failures. You can stand for highest medulloblastoma, so what I was talking about was for the average studies, essentially.
Sorry, Abdulaziz, I think we lost your voice.
Who had these features in their histopathology. This is
Abdulaziz? For Abdulaziz, sorry, I think we lost your voice. Sorry for this technical problem. I'll try to fix it soon.
I'm sorry, my connection dropped. Just going to reshare my screen. Can you hear me?
Yes, we can, Dr. Abdulaziz. You can share your slide.
Let me see. Can you see my slides?
Yes, we can.
Thank you.
It's not
So,
in the slide, sharing slides, the presenter mode, Abdulaziz.
Shloan?
It's in the presenter mode, not the slide presentation. Yes.
Okay. What about now?
Now it's good.
Okay. So this is the study, the St. Jude Medulloblastoma 96, which showed improved outcomes for the high-risk patients with pretty intense chemotherapy with cyclophosphamide and vincristine after radiotherapy. cisplatin. This is the kind of the most recent study for the high-risk medulloblastoma. It was the ACNS 0332. Essentially, in this study, they wanted to escalate because we've struggled with the high events with high-risk medulloblastoma. So in this study, they tried to use isotretinoin as a way to improve outcomes, also adding carboplatin as well to the combination. And what they found in this study that for retinoic acid, it was futile, and carboplatin only improved outcomes for the group 3 in the high-risk patients. And this is essentially what came out of this trial. So the other thing with what has happened in the current era is the molecular subgroup and prognostication. So this work came out of, I believe, Germany, where they recognized that that medulloblastoma is pretty heterogeneous, as we've noted earlier from previous series in the 70s, that histopathology indicated better prognosis. And the current era, they tried to look for transcriptional profiling for medulloblastoma cohorts. And this has shown that we actually have pretty distinct groups with different outcomes. This study came out in 2012, and it was shortly adopted by the CNS classification by the World Health Organization. And now it's the standard of care that you classify these patients according to their molecular subtypes, histology, as well as clinical presentation. There is also a lot of work that was done in radiology, which I didn't have time to include in this presentation, but feel free to check it out, where they try to also find radiologic features that can indicate the molecular subgroups. I believe they looked into ADC maps and things of that nature that can be pretty indicative of a prognosis and the molecular subtypes, which is pretty cool, I think. In terms of future directions, so now we have 2 studies in the block that are looking into escalating and de-escalating using molecular prognostication. The study by St. Jude, CGMB12, and there is also another COG study, CNS 1422. So the St. Jude study, they stratified these patients according to their risk groups as well as their molecular subtypes. And they have this elaborate schema where each stratum of these patients will go through a different treatment pathway. I am not pretty sure. I think they closed accrual and they started looking at the data. And I heard, don't quote me on this, that for the wind type low risk, the 15 gray CSI, I don't think they had a lot of failures in this arm. But this is all. Nothing has been published yet, but these are the reports that I've been getting from friends and colleagues. The other study is the CNS 1422, pretty similar design. The only difference is that they're dose de-escalating to 18 for CSI rather than 15, which was done by the St. Jude group. So the last few slides I just want to talk about the role of proton therapy, which is technology that I worked on when I was at the University of Florida. And I looked at some of the data for proton therapy pediatric patients. These are essentially some of the data that came out of, I believe, the US, where they looked at long-term cognitive academic outcomes among pediatric brain tumor survivors, where they compared proton versus photon radiotherapy, which is, in a sense, is a way that we are de-escalating the modality rather than de-escalating the dose or the chemotherapy intensity. Is using a better technology that can spare large proportions of the brain. So this is a very nice study. They looked at different cognitive parameters. They looked at IQ variables, memory variables, attention variables, academic fluency variables. And then what they found is that if you were to treat someone in the brain, this is kind of a general thing. It's not necessarily for CSI, but generally, if you treat with a focal group with proton therapy versus a photon therapy, that the proton therapy patients outperformed the photon cohort. There is also CSI proton versus CSI X-ray or photon. Also, there was a difference in attention and impulsivity. The proton essentially exceeded in most domains for these patients. However, if you're treating someone who has a high risk medulloblastoma and you're treating 36, I don't think treating with proton provides a lot of neurocognitive benefit for these patients. However, for select patients where you think you can spare them a lot of these cognitive side effects, I would recommend looking into proton therapy as an option. There is also this study by Toran Yak out of MGH, and it looked into global health-related quality, and proton therapy patients have done exceedingly well in comparison to the photon group. There is also a study by Brown, I think, out of Minnesota, where they looked at acute toxicity with proton therapy for CSI versus photon treatment, and it's pretty clear the difference. Although, to be fair, this is kind of an archaic technique to treat now with POP, but you get to spare a lot of the normal tissues here. The proton treatment improved most of the side effects of these patients. And lastly, there was this talk about neutron scatter for proton treatment. And there was a lot of reports where they indicated that proton treatments actually may increase the risk of second malignant neoplasm for patients who are treated with proton therapy. And there is this idea that using a double scattering technique can create a neutron scatter, which may lead to increased risk of second malignancies. This is a nice meta-analysis, I believe, and systematic review completed by the out of Ohio, and they looked at the rates of second malignancies from 24 studies, and essentially the rates were pretty comparable between photon and proton. And now we do have better technology with pencil beam scanning beams for proton, where you avoid using the double scattering technique that is associated with a neutron scattering and possibly increasing the risk of having second malignancy. Having said that, they did note in this metastasis that the latency to get a second cancer was shorter for the proton cohort. They believe as well that that might be related to neutrons. However, when the decision comes into treating someone with proton versus photon, you have to factor in a lot of factors. It's not just basics of radiobiology and toxicity. There is also financial toxicity, inconvenience, having to travel abroad for these type of treatments. But this is something that I hope that anyone who treats pediatric patients consider these, consider proton at least whenever he's presented with a patient with that needs CSI, or he needs to be treated to larger volumes. Thank you for your time and attention, and please feel free to ask questions.
Thank you, Dr. Abdulaziz, for that valuable presentation. It really increased my knowledge about the proton therapy and when should I actually transfer a patient to proton therapy. I do have a question. What you mentioned is about CSI. If we're giving 36 grays, you wouldn't expect that there would be a difference in decreasing the risk of cognitive dysfunction, whether we're using proton or photon. But should I still consider sending patient for proton if I think that it is feasible for even high-risk patients with who am I expecting to give a high-dose CSI?
Well, it's a tough decision, to be honest. Most of the patients, when I worked at the University of Florida, most of our patients came from abroad, either from Canada or from New Zealand, UK, and most of them were low-risk patients where you believe that doing that extra step of using proton therapy would provide them with a better opportunity to lead a better life, better cognitive outcomes. But when it comes to these 36 patients, patients that you have to treat to 36 grays, it's not just the using the proton or not. They will have to go through like intense chemotherapy that is pretty toxic, and it can affect their cognition, hearing as well. So I would discuss that with the family, that there is some benefit in terms of maybe reducing the chances of them having like hypothyroidism and things of that nature. Also, maybe reducing the dose to their spine, better hematological toxicity, things like that. I may consider that discussion, but 36 is way above like all the constraints for like temporal lobes and all these cognitive parts of the brain that are related to cognition. So it's a discussion. I would urge you to have them with your patients, but the benefit is not that great with proton, if it's a high-risk patient, to be specific. Yes.
Okay. Anyone else has any question? I do have a technical question. When you're doing proton therapy, do you do the vertebral body sparing technique, or do you?
So I think at this stage, it's pretty experimental. I think there was an Astro presentation from St. Jude. I think Thomas Merchant presented that. They're looking into it. I would not do it right now, especially with like a lot of uncertainties. We don't have a lot of good data yet, but I think we're headed toward that vertebral body sparing proton therapy, maybe highly conformal photon, I don't know. But I think that is something that will be available in the future. But I don't do it. I haven't done it.
Right now, you
myself.
include the
Go ahead.
higher vertebral body with the high dose, or do you keep it to the 50%, or is it a
We
gradient?
we use for proton, we used to at least at the University of Florida, we used 18 grays ice dose line that covers the whole vertebral body.
Okay, interesting. Any other questions?
I have a question. Do you hear me?
Just go
Yeah.
ahead.
Yes, this is Dr. Hani Mu'mina from King Faisal in Jeddah. I see some practice in high risk medulloblastoma, boosting the surgical bed only, not boosting the posterior fossa. What is your practice usually for high risk medulloblastoma?
So the ACNS 0331, I think they used a CV of 1 centimeter. What we did at the University of Florida, we used 5 millimeter expansions on the surgical bed for both average risk and high risk patients. But boosting only the surgical bed, I would honestly, I don't know dosimetrically what is the difference if you're doing this. And the other thing is, I worry also about missing some microscopic disease, albeit we have better technology, better imaging now. But if there is one thing I learned from reading the literature on medulloblastoma, it's essentially it disseminates. It has like this behavior of going into the crux and the values of the brain. So I would still at least do 5 millimeters expansions, not just the surgical. But I heard that there are some centers in the US that they're doing this other than University of Florida, but I'm not sure if they have their own institutional data that shows that there is of just boosting the bed. Does that answer your question?
Yes, I believe still the standard of care is boosting the posterior fossa for high risk based on evidence. And most the evidence is for the low risk, but some practice they are boosting the surgical bed.
Yes, with the 5 millimeter. That's what we did at the University of Florida.
I do agree with Dr. Abdulaziz. I stopped using the posterior fossa even for the high risk patients. I usually do the surgical bed with 5 to 10 millimeter expansion. It does make a difference in the doses to the cochlea, and I haven't seen any relapses, except in multifocal diseases. Then those patients, I get a bit worried, and I still give the entire posterior fossa. But if it's just a unifocal lesion, even high risk or anaplastic, I give only surgical bed.
But do we have evidence for that, or this is just institutional practice?
This is mostly, at least from my experience, was an institutional practice at the University of Florida. They have their own in-house data. Go ahead, Lulu. Yeah.
As well as my experience with Princess Margaret Hospital sick kids. So we only give the surgical cavity. No one gives the entire posterior fossa anymore. And I do agree with you. The evidence is just for the standard risk, but since the data from the centers itself, after decreasing the margins, did not show any worse outcome.
And Dr. Momina, by the way, the data for boosting the posterior fossa, the whole posterior fossa, came through also institutional practices. Essentially, it was the original case reports by Bloom and Jenkin and the other groups. So it is a difficult decision. I agree with you, but the toxicity, it's pretty toxic, and especially if someone is on high risk protocol and they got pretty hefty chemotherapy. If you can spare their cochleas, I would encourage that you do that. But I'll look at what is published out there, if there is any like good numbers of institutional case reports and case series that shows that there is no risk for relapse. But as Lulu, this has been done at least at the University of Florida for the past, I think, 5 years.
Assalamu alaikum.
Assalamu alaikum wa barakatuh.
This is Dr. Adnan Al-Habshi, radiation oncologist, Johns Hopkins. Thank you very much. I'm sorry I joined at the last few slides. If you don't mind, I have 2 questions. I treated, subhanAllah, just yesterday I saw this patient. I treated him in 2016, 60-year-old gentleman with medulloblastoma. I treated him with craniospan and boost to the posterior fossa, and the patient cured. After 6 months from the treatment, he developed enhancing lesion in the midbrain. And everybody in the tumor board said, and the radiologist, this is relapse. And we started to think about second options, chemotherapy, high-dose chemotherapy, stem cell transplantation, up to that level. And then we said, no, we'll treat him if he started to be symptomatic. This lesion completely disappeared. And the patient is still alive now for 7 years. The only thing I felt sorry about this patient is the cognitive function. Is there any way to minimize it by hippocampal sparing, for example? I missed to give him the memantine as well to minimize the side effects of the radiation therapy for this gentleman. Now he's 67 and he's with good intensive physiotherapy. He's walking. His memory not that bad actually. He remembered me and we have a very nice chat, and really he's in good shape. Let's say cured from high risk. There is a residual disease, not standard risk. This one, do you think the hippocampal sparing in pediatric viable question, or you don't think that?
So what we used to do is we would contour the hippocampus and try to minimize those going there. But if you're treating to 36, you're already exceeding that. So the problem with medulloblastoma is it is the frontal lobes, cribriflates, temporal lobes, they're common sites for, from the days of 2D radiotherapy, they were common sites to have failures. So I would advise against sparing the temporal lobes. And there is also the evidence from M4 protocol where they basically volume de-escalated and spared the supratentorium. And they had a lot of failures in the supratentorium. So I would advise against it.
Do you recommend also small dose of memantine to minimize also the effect of radiation?
I think most of the peds hemoncs in the US, they would prescribe memantine for kids, but it has a different dosing regimen. I'm not sure.
Okay.
But you could ask the peds hemoncs. Go ahead.
Yeah, the second question, if there is enhancing lesion in the pons or in the midbrain, and really I have the radiology report that this is the relapse and we don't know what to do. Nobody wants to take a biopsy from this eloquent area. And we are really about to give him chemotherapy, but this disappeared. I don't know what happened, really. Did you face anything like this with your patients?
Not at all, no.
I remember Dr. Buffet from Princess Margaret, from Sick Kids Hospital. He mentioned sometimes in his presentation that Sometimes if we see something enhancing lesion after radical course of treatment, don't rush with another surgery in medulloblastoma. And also, if I'm not wrong, about ependymoma as well. He's not rushing to do another surgery, mutilating surgery for the kid, because he showed us some cases. We thought that it is a relapse and it vanished by itself without any treatment. But really, I started to think about those kinds of cases because I saw this patient and I was very sorry about him, but now he's surviving and without any, apart from the cognitive function deficits.
That's great news. There is also these advanced techniques now with MRI, I think perfusion, diffusion studies. The neuroradiologists will be more well-versed in this, but they do have way know, like with a great deal of certainty, if this is actually a relapse or not. And the other issue is if you get an adult neuroradiologist, they're not attuned to medulloblastoma. It's not common in 60 years olds. So maybe review it with a pediatric neuroradiologist and see what they think, if this is something that this is a relapse or not. Because sometimes they have their own, I believe, protocols that they use to distinguish the different types. Even for molecular types, they use imaging to know as well.
The most interesting thing that in adult, nobody likes to give any chemotherapy, like in pediatrics. There is a study from King Faisal Specialist Hospital by Dr. Yasser Khafaja. He recruited a very good number, I think up to 100, adult medulloblastoma. And there is no difference in the outcome between the adult and the pediatrics. That's why we encourage to treat the adults. But the chemotherapy, nobody will give chemotherapy. So most of the cases treated by only radiation therapy. Do you have any other ideas for adult?
I think Dr. Yasser knows this way better than me. I will talk to him about this. I haven't treated any medulloblastoma in my fellowship.
Dr. No, we had few adults having chemotherapy, but it really depends on the medical oncologist. Sometimes we can push for it.
Yeah, but there is no evidence, according to Mu'mina. There is no evidence. There is no paper about.
The outcomes are actually better with the chemotherapy, and you still can decrease the dose of craniospinal if it's not a high risk. So we still can give the patient 24 instead of 36 if he's getting chemotherapy.
So extrapolation from pediatrics results.
Well, the adults that had both treatments are actually surviving very well. And even the adults who got only radiation treatment, I think most of the adults who get medulloblastoma have a better prognosis pathology. Usually those are the sonic hedgehog a molecular subtype, and they had a better prognosis. To tell you the truth, I have seen a 36, like giving radiation 36 grays, having problems with cognitive function early than those patients I gave 24 grays as a CSI. But try to convince your medical oncologist. On the other hand, I have seen those adult patients have been given chemotherapy, and then they develop severe neutropenia and thrombocytopenia, and we have to stop the treatment. And they can never get back into chemotherapy, and their radiation is delayed. So that's a dilemma, because the adults do not recover from chemotherapy as quick as kids. But if you can convince your medical oncologist and the patient is not really old, especially those patients who we consider adults, but they're really not adults, like the 16, 17 until 20 years old. Those are still young patients who deserve to get the full treatment or the best treatment to decrease the side effects, the long-term side effects.
Just one question. Did you give them any memantine?
No, I've never used memantine, actually. No, I hope I can, but no, I've never used
it. Oh, really?
Do you prescribe it yourself, or do you?
Just one. Yes, it is very cheap and nice. According to the RTG, we give 5 milligram in the first week, AM. Second week, 5 milligram, AM and PM. Third week, 10 milligram in the morning and 5 milligram in the evening for 1 week, then 10 milligram twice daily for 6 months. Most of the patients tolerating this dose. Just I want to add one comment. Really, it rings in my brain whenever I see a patient with medulloblastoma. When I was at King Faisal Riyadh, I treated few medulloblastomas, a lot of craniospinals for germ cell tumors and medulloblastomas. One of the patients noticed that he cannot eat anything unless it is red in color. Believe it or not. His breakfast is ketchup, only ketchup. And he can eat the apple and strawberry. And he survived the whole treatment. Did anybody notice something like this? Or I'm just exaggerating the issue? Red thing with medulloblastoma when he was treated with craniospinal radiation therapy.
No, I have not.
Looks like crazy, but really it happened to me. Once the patient with the medulloblastoma, he cannot eat due to nausea or vomiting, I asked him just to eat a red thing, red color things. And believe it or not, 2 of my patients tolerating that, and they went through the treatment without any difficulty. Some of them, by the way, they are losing weight due to nausea and vomiting and loss of appetite during heavy radiation therapy, as you mentioned, with neutropenia and also drop in hemoglobin. Last blood test during the treatment or not? Like CBC regularly every week? Or?
Can you repeat your question? Because the connection was dropped. I did not hear the.
Do you do CBC every week for patient on craniospinal?
Usually it's done by the pediatric oncologist. If the patient is not getting chemo, yes, I do. But I never interrupt the treatment. I move from giving CSI to the boost if there is a drop in the blood count. So you just give a break from the CSI, but I continue with the boost. And then you look at your counts. If they're recovering, you just go back to the CSI. There is one question though in the chat. How do you salvage young patient progressing under initial chemotherapy if you are proceeding with CSI for patient less than 3 years old? Which dose regimen do you follow? Dr. Abdulaziz, do you have any?
The practice in the US, now there is the ACNS 1422, I believe, which is for infant medulloblastoma. Essentially, they delay the radiotherapy for these patients. There is also the HIT START trial, I think HIT 2 and 3. There is the HIT 2000 trial for multinodular subtype of medulloblastoma. So there is no rush to give these patients radiotherapy if less than 3 years. I would talk to the PEDS hemonc about either a HIT protocol type of treatment or a HIT START of treatment, or if you have ACNS 1422 to enroll these patients in.
Okay.
Dr. Amin Al-Amir is raising his hand long time ago.
Go ahead, Dr. Amin.
Thank you very much. Just follow-up question for Dr. I do have some comments, but Dr. Adlan was asking about the chemotherapy in adults, right? So are you asking about concurrent part or just adjuvant part? Is it average risk or high risk?
Either concurrent and the adjuvant.
Okay,
Nobody did chemotherapy.
Yeah. Well, an adult, we don't typically give chemotherapy, and I agree with the comment that they have prolonged neutropenia and long break from the treatment. It's not like the kids, when they have neutropenia, they just catch up quickly and recover quickly. So with radiation therapy alone, Adnan, interestingly, radiation therapy alone with craniospinal, almost all of the patients they will have break, which is bad in a grade 4 tumor, rapidly growing. Some of them, they finish the treatment 7 weeks. I'm talking with my patient, some of the patients that I treat during my fellowship. So I agree with the comment that even without chemotherapy, it's hardly to get adult patients into the treatment because of the low count. And there's no evidence for chemotherapy. There's some phase 2 trials. So the Prince-Mark Hospital guideline, for instance, they don't give chemotherapy. Also Sunnybrook, although different practice among different physicians, but it's not commonly used in adults. There are nice German trials showing some evidence, but it's problem, Adnan, is very hard to accrue patients. It's a pediatric disease. Maybe adjuvantly, it's easy to give it for high-risk patients, although our practice used to be at King Faisal not to give it at all. But now we're having different neuro-oncology, so we might use it adjuvantly, but not concurrently. Regarding your comment on hippocampal sparing, I totally agree. As you know, in the past, the failure in the cribriform blade, it's not just because it's a site of failure, because it's a subarachnoid space that was not covered. So you need to be very aggressive in treating not the whole brain and spine, but also going down to the base of skull, the exiting foramen for nerve, for cranial nerve, like, auditory canal. You see some failure there. So you need to be very aggressive in chasing up any CSF or subarachnoid space. So I don't think anyone will do the trial. But I agree with you. People might look into the, those de-escalating, say, for maybe favorable molecular subgroup, which is not an adult typically. This is in pediatric. And also, you talk about some enhancements in the pons or in the midbrain. Very interesting. We don't know what radiation causes to the vasculature and causing this leaky, enhancing things. So I don't treat, medulloblastoma that common because it's a pediatric disease. But in adult, I've seen it with GBM when you have pseudoprogression, with vestibular schwannoma when you have pseudoprogression. But also, if you treat trigeminal neuralgia, the intact nerve, it just hits the nerve. During follow-up, it's very common to see enhancement corresponding to the high-dose region. This is just in field. So if your patient is asymptomatic, I agree with you. I might not rush in to give chemotherapy, maybe observe, repeat imaging. Things might change. But also, like Dr. Aziz Al-Ghamdi was suggesting, doing MRI, perfusion, spectroscopy. But it seems that if the area is very small, maybe those imaging doesn't help much. And last thing is Dr. Hani Mu'mina comment. He make a very good question about treating the posterior fossa, like the whole posterior fossa versus just the surgical bit. So I agree with the colleague who treats only surgical bit, even for high risk, because treating posterior fossa came from nowhere. It's just the standard to give craniospinal, then followed by something. And what is this something? It used to be posterior fossa, whole posterior fossa. Then with time, they start to shrink the field. And I can tell you, Dr. Hani, we did this exercise 12 years ago, and I joined King Faisal. First case I treat just posterior fossa and was high risk. And two of my senior colleagues was questioning this. So we review the evidence. There is no direct evidence, but we start seeing major randomized group of trial shining from whole posterior fossa to focal. So it starts to be more and more common practice. So most of us now is treating just the posterior fossa. So this is just a follow-up comment on the previous things. But I do have one question maybe to the whole group, and one comment, and if the time allowed. So Dr. Abdelaziz was saying some very interesting things about radiology. It might be predicting the molecular group of patients just based on imaging. And I agree with this, Dr. Abdelaziz. And for instance, diffusion-weighted image is very good in selecting one subtype of medulloblastoma. So if there is no diffusion restriction, it's a surprise, because most of the medulloblastoma, or all of medulloblastoma, have significant restriction in DWI. So if you have no diffusion restriction, this is likely a TB53 mutation, which is one unfavorable subtype of the sonic hedgehog. So other thing is MRI spectroscopy. Amazing. There's lots of ongoing research about this. So looking at different metabolites, you can know roughly are you dealing with sonic hedgehog versus group 3 and 4, which lumped in one area? So for instance, if you have low level of lipid, high level of creatinine, so low lipid, high creatinine, and detectable taurine, this is likely group 3 and 4. If you have undetectable taurine, this is the sonic hedgehog. So it's kind of lots of things on imaging. But what I want to say, the imaging now is biasing the pathologist. And I can tell you, not in medulloblastoma. In glioma, for instance, some sign on radiology is 100% specific. Even sometimes, I can tell you one case labeled as IDH wild type. And during the tumor board, we told the pathology that there's a T2 flare mismatch. He went back to the sequencing and he asked to do different analysis for different rare subtype of IDH mutation, and interestingly turned out to be IDH mutant, just based on radiology. So it's amazing, Yani. It's very amazing how specific sometimes the radiology and telling you what is the molecular subtype of the tumor. So last thing, this question to maybe Dr. Aziz or the group. Now we have different subgroup of medulloblastoma. So we know that it's a heterogeneous disease. It's not a single disease. Would this change management in any subgroup of patients? So we have one subtype, sonic hedgehog, group 3, group 4. Do you de-intensify the treatment, or would you treat more aggressively with any type of treatment, surgery, radiation, chemo, targeted therapy?
Hi, Doctor. Thank you for your question. I think there are running protocols now. I mentioned the CGMB 12, which is from St. Jude. They do have different strata, and if you look at their elaborate scheme, they would escalate, de-escalate according to molecular subtypes. So it's, as of today, I would stick to my guns and just follow the standard average risk, high risk paradigm until we have more mature data. I know for sure that the 15 grays CSI are, at least from folks I know from St. Jude, that this is a group where they didn't have a lot of, I think they had a few failures. So I know that the de-escalation for wind type will be something in the very near future. But escalating because we're still having problem with escalation for high risk. We haven't found the best combination of radiation and chemotherapy where we can escalate and improve outcomes. The best thing we have is SJMB 96 for now. So I think this is something down the pipeline. I think it's coming. I think it's going to be something happening really soon, at least for the wind type from what I'm hearing.
Yeah, I agree. And I see people for wind types, some of them go 15 up to 18 gray, which is very, very intriguing.
السلام عليكم ورحمة الله وبركاته. علي Valverde, if you would like, let's تسمحوا لي, I have some few comments about the discussion. I think this is really interesting. And just to quickly go back to Dr. Adnan Al-Hibshi's questions regarding the adult medulloblastoma. If you go to the protocols, most of the COD protocols, they stop at 22. So they do not include any patients beyond 22 years old. So treating these patients after 22 years old is completely unknown. I would be very careful to de-escalate the craniospinal dose if the patient will not receive chemotherapy. So this is part of Dr. probably Adnan's question. If the patient is not receiving chemotherapy, I would not go with 24 gray. I would rather go with a 36 gray craniospinal. I would say that in our hospital, young patients who are, I wouldn't go to the patient that he gave as an example, but younger patients, we always give adjuvant chemotherapy. Concurrent chemotherapy, that we don't give them concurrent vincristine. We go with the standard craniospinal boost, and then they go with the adjuvant chemotherapy. So we had actually few patients with medulloblastoma, adult medulloblastoma, and our medical oncologists are very keen to give adjuvant chemotherapy. I know it is a rough course of treatment, but it goes in most of our patients. Now, the other question regarding changing the practice with regards to the methylation subgroups, we do escalate if the patient is group 3 in King Fahd Medical City. So group 3 usually have a very bad outcome. And even though if there is no evidence of seeding and there is nothing, we always do escalate, and we go with the 36 craniospinal plus boost. Even though we had only few patients, but most of them had recurrences after very intensive craniospinal radiation with concurrent vincristine, carbo, also not only vincristine, and again adjuvant chemotherapy, and still we have failures in those patients. I would be very careful with the dose de-escalation, even for the Wnt, unless the evidence is proven. So I would escalate, but not de-escalate doses. And I hope that would help with some of the answers. The last part, which is the boost volume. Boost volume for medulloblastoma, let me quickly just highlight one of the studies from MD Anderson showed higher risk of recurrences or higher rates of recurrences using 1 centimeter CTV compared to 1.5 centimeter CTV. But still, I think the common practice is to do CTV expansion rather than whole posterior fossa for pediatric population. And I know most of the current studies are using at least the St. Jude's and other studies, they're using 0.5 centimeter only because they think it is enough to give the craniospinal than having the boost with a small ATV margin. The changes in the brain stem, I think it was published by Dr. Indelicato from Florida, but that was using proton therapy. And in his publication, I had a good discussion with him regarding the findings. He thought that most of the patients that had the changes in the brain stem, it came back. And he actually suggested lowering the dose when it overlaps with the brain stem. Now, I would say our current practice in King Fahd Medical City, we usually when there is a large volume overlapping with the brain stem, I don't and we don't request 100% coverage, just to make sure. So 95 is our acceptable dose coverage when the volume overlaps with the brain stem, just to lower the dose down on the brain stem. And alhamdulillah, we have never seen any problems with brainstem necrosis or even MRI changes suggestive of brainstem necrosis. So I hope that would help others during their practice with this very important disease. Thank you.
Ali, can I ask a quick question?
تفضل.
Yeah, so you're saying for group 3, you don't give low dose like 23.4 plus chemo, right? Or I missed it.
Yeah, we give 36 على طول. Group 3 we give 36 gray.
So regardless if the patient had say disseminated disease, or so if he has no metastasis, and do you do NMIC amplification, or by just default of having group 3 you're not comfortable to give lower dose?
Well, we usually do the full panel. We send the molecular testing outside, the methylation group outside, and it comes back with the full panel. And once it is confirmed group 3, we some patients we already started as average risk, and during treatment when we receive the molecular results back and the methylation back, we escalate the dose to 36 gray craniospinal.
Interesting, and I agree with your comment for adult, not to drop the dose, because typically most of the adult is the sonic hedgehog subgroup, and if you want to, which I don't agree with dropping the dose, but at least if you want to drop the dose, you might want to do the TP53 mutation. If it's mutated, then this is high risk by default. So why?
I never. By the way, sorry, maybe I didn't put my comment accurately. I never drop the dose for adults medulloblastoma.
You're saying.
But if someone is trying to drop the dose, make sure you give chemotherapy.
I got your comment. You're not favoring dropping the dose, which is I totally agree. We don't.
Yeah, exactly.
Well, there's two things. There's two things. If you give adult chemotherapy, typically with CSI, they just have prolonged low count, like neutropenia, one of the comments mentioned. I totally agree with it. Then it's just you're in trouble. So this is A. B. If you want to do it off trial, at least you want to make sure that you're not having high risk by default of having bad molecular feature. So this is my suggestion. Thank you.
Thank you very
Dr.
much.
Majid. Dr. Majid, do you have a question?
Assalamu alaikum, Majid
Salam
Rahman. Actually, first of all, I would like to congratulate Dr. Abdulaziz for an excellent talk. And I like really him looking into the evolution of the standard of care, which is, we are always standing on the shoulder of giants who precede us, and appreciation of this is very evident in his presentation, which I really liked. My 2 cents is not really a question, it's just the posterior fossa versus tumor bed volume. This has been looked into in a randomized fashion, phase 3 trial in the same Jeff Mahalski's paper, because they looked into de-intensification of the of 2 elements, the CSI dose, which failed, and the posterior fossa versus what they called in involved field, and they showed it to be non-inferior. It's in the Children's Oncology Group trial ACNS 0331. So it's actually, we have level 1 data to support that. Thank you.
I do agree with you, Dr. Majid, but that was for an average risk patient. The question was about the high-risk patients. Regardless, we even in high-risk patients, we stopped doing the posterior fossa.
I had the survival curves. These are the survival curves. But ACNS 0331, as Lulu mentioned, it was for average risk patients.
Yeah.
Yeah. No.
Yeah, but what I'm saying is not only practice. It's been looked into phase 3 level. It's been pioneered by Arnold Paulino since the 2000s and became standard of care now. I'm not sure if anyone is doing posterior fossa in mainstream practice.
I don't think so either. I haven't seen anyone that does it. At least at University of Florida and
I believe it's an
DMH.
obsolete practice by now.
Yeah, I stopped a long time ago.
Yeah, so that goes to both average and high risk.
And high risk, exactly.
Yes. Thank you.
I don't see any raised hands anymore.
Can I ask a question to the group?
Sure.
With such molecular classification and having some with the prognosis, we talk about de-intensifying the radiation dose. How about surgery? We are always concerned about morbidity from surgery, posterior fossa syndrome, and sometimes it's have long-term sequelae. So anyone want to comment on this?
In what regards, Dr. Amin?
Sure. Would you de-intensify the extent of surgical resection, which used to be very strong prognostic factor, categorizing the patient to high risk versus no high risk, and the current classification?
Let me tell you, just a little from our experience. We noticed that most of the patients that we send back for surgery, because the volume left behind was more than 1.5 square centimeter, they ended up with either complications or...
I'm saying beforehand, intraoperatively, you send the frozen, you do the immuno, then if it's went subtype, you just ما تتحمس واجد. This is what I'm saying. I'm not talking about redoing resection after surgery was done.
I'm not sure if you can have the results of WINT or the methylation subgroup.
You can.
From frozen?
You can.
Nice.
Yeah, you can. They do it in sick kids. Basically, what you can do in frozen, you send the tissue,
لا
and
بس ست
then
بس هنا يعني احنا
I'm
الان
telling
الميثيليشن
you,
takes few weeks
Elliot.
before we give it.
Okay.
احنا يعني
Yeah,
our
you don't.
methylation and molecular takes few weeks before we give the results back.
Yeah. Just hold on. So you don't need to do molecular. What you do is the immunostain, which is very specific. So you send it for beta catenin, GAB1, and YAP. So if it's beta catenin positive, then this is it's been done. This is I'll tell you one of the trials that was published. So if it's beta catenin by immune is positive, this is the Wnt activated pathway. Even YAP is positive for both. Sonic Hedgehog and Wnt type. And then Dr. Redka from SICKIS, a few years ago, he told us they're leaning toward this. Why? Because especially if the tumor is in the vermis, where there is most of the cerebellar nucleus and crossing pathway, then this is the chance of posterior fossa syndrome is high, leaving patients with long-term sequela. So there is a nice paper in Lancet Oncology, 2016, by Dr. Ramaswamy, suggesting that molecular is more strong than extensive resection. But most people in a conference and meeting, they don't buy it, Ali, because still they believe the more resection to do, the better. But the bottom line is do as safe resection as you can do. But once you're in an eloquent area or area that, say, you're worried about having complications, then just leave it, especially for Wnt subtype.
Dr. Amin, regarding de-escalating the doses, if you still have significant residual, which is higher than 1.5 cc, even in the Wnt subgroup, in the clinical trial, they're still considered as a high risk. So they're in the high risk arm. So for the Wnt subgroup in the clinical trial, there is the very low risk and then the average risk and the high risk. And in the high risk, that includes the 1.5 cc. So those did not actually under that clinical trial, which we don't have result for yet, they did not de-escalate. They're still giving 36 from what I'm seeing.
I'm not asking about the de-escalation of radiation. I'm asking about the extent of resection. Doesn't really matter. And like Dr. Ali said, most center, they won't adopt it, but it's something that worth discussion because some center believe in it and start publishing on it. And it makes sense for if you have a midline or tumor in the vermis, it makes sense. But I agree with your comment completely, Dr. Lulu.
Yeah, I'm not sure if I'm going to de-escalate for any subgroup right now because we don't still have the results. Most of those clinical trial, even the COP trial has finished accrual, but we still don't have any results.
I'm saying about de-escalating the radiation dose, right?
Yes, de-escalating the radiation. But for the surgery,
yeah,
like I don't think this has been studied.
We are not a surgeon, but I'm saying this is being discussed now. A few years ago, we got Dr. Ratka from SICKIS. He came to Saudi, took an SANS meeting, and we were impressed by his practice. But this is something that I want to mention to tell you things might change in the future.
I hope so, because yes, it is a lot of morbidity for those kids if an eloquent area is damaged during surgery, and usually this is not reversible. Yes, posterior fossa syndrome is reversible, but surgical damage usually is not. I hope we can de-escalate, but for now, I don't think I will. I would still ask the surgeon to go back if possible.
Yeah, sure. I agree with you. Sorry, I was disconnected. But yeah, I agree with you. Most of us still go with the standard thing. Yeah.
So I guess there is no more questions from the group. And by that, we do conclude our presentation for today. So thank you, Dr. Abdulaziz, for your great presentation. And thank you, everyone, for attending.
Thank you so much for attending.
Thank you.
Lovely
Thank you,
discussions.
everyone.
Thank you.
Thank you.
Assalamu alaikum.